Good morning, everyone. We are Group 4 and we will be presenting today a case of a 9-year-old male from Mandaue City who was admitted for fever and tachypnea. For the history of present illness, 4 days prior to admission, the patient had onset of intermittent fever with a maximum temperature of 39 degrees Celsius and was given paracetamol. There were no other complaints verbalized, and it was noted that the patient had good appetite, no vomiting, no abdominal pain, no cough, no coryza, and no mucosal bleeds. 3 days prior to admission, the fever persisted, thus, the mother opted to have CBC and urinalysis done. And the results are as following. No consult was done and no other symptoms were noted. Fever was monitored, and the mother decided to self-medicate with amoxicillin clavulanic acid twice daily, and paracetamol was continued. The morning prior to admission, the mother decided to bring laboratory results to an attending physician who suggested to have repeat CBC. 1 hour prior to admission, while waiting for the CBC result, the patient complained of thirst and fast breathing. Patient was then brought to the emergency room. The CBC showed hemoglobin of 18.1, hematocrit of 55.9, WBC 6.8, and platelet 30. For the prenatal history, the mother was 34 years old with an OB score of G2P1 1001 at the time of pregnancy. Prenatal care was started at 8 weeks age of gestation with an obstetrician and with regular visits thereafter. Prenatal medications include multivitamins plus iron once daily and also calcium once daily. Ultrasound was unremarkable as claimed. Mother was GDM on diet controlled, a non-alcoholic and non-smoker with no history of illicit drug use. For the natal history, the patient was delivered term via primary cesarean section secondary to failure of descent as attended by an obstetrician with no known complications. He had good cry and suck and weighed 8 pounds. For the feeding history, the patient was exclusively breastfed until 6 months, semi-solids were introduced at 8 months, and solids at 1 year old, supplemented with breastfeeding. Patient is fond of eating sweets and drinking chocolate milk. For the immunization history, it is shown here in the table below. It is also worth notating that the patient did not have Dengue vaccine.
Past medical history. The patient has no history of previous hospitalization, no known prior history of dengue infection. Personal and social history. The patient currently resides in UCMA Village Apas, Lahug City, Cebu, with his parents and older brother. Mother works in the radio department and the father is a government employee. No recent history of travel, no clustering of influenza-like illnesses in the family, no known contact with COVID positive within their neighborhood. Physical examination of the patient at the ER. General survey. Drowsy, in respiratory distress, vital signs BP 80/60 mm mercury, heart rate 152 beats per minute, respiratory rate 49 cpm, temperature 37.2 degrees Celsius, O2 sat 88%, weight is 58 kilograms, IBW is 29 kilograms, the length is 144 centimeter, and the BMI is 27.9. Skin is cool and clammy, pale, mottled, negative for rashes and negative for lesions. HEENT consists of a positive circumoral cyanosis, pale palpebral conjunctiva, and a positive alar flaring. Chest and lungs consist of positive coarse crackles, bilateral decreased breath sounds in both lung bases. Cardiovascular system. Distinct heart sounds, tachycardic, negative for murmurs. Abdomen is slightly distended abdomen, soft, negative for hepatomegaly. Extremities, cool, fair pulses, CRT is 3 seconds. Mental status, drowsy. Pupils, isochoric, 3 mm reactive. EOM is full as observed. Respiration is tachypneic, labored, and in distress. The muscle is in full ROM.
For our case, our impression is severe dengue fever in hypotensive shock. The basis of this impression is that the patient had a fever and it persisted for 2 days. He had urinalysis and CBC which showed hematuria, and CBC is unremarkable for the first test, and a second CBC was done and it showed increased hematocrit and thrombocytopenia. Patient did not have Dengvaxia vaccine. Also, for the patient's vital sign, it showed hypotension, tachycardia, afebrile, and in respiratory distress. Lastly, for his physical exam, it showed that his skin was cool and clammy, pale, has mottled skin. For his HENT, it showed positive circummural cyanosis, pale palpebral conjunctiva, and positive alar flaring. For his chest and lungs, it showed positive coarse crackles, bilateral decreased breath sounds in both lung bases. And lastly, his extremities were cool, with fair pulses, and CRT was 3 seconds.
Case discussion. Epidemiology. According to WHO, dengue is the most rapidly spreading mosquito-borne disease in the world. In the last 50 years alone, incidence has increased 30-fold, with increasing geographic expansion to new countries and in the present decade from urban to rural settings. An estimated 50 million dengue infections occur annually, and approximately 2.5 billion people live in endemic countries. Transmission. The virus. Dengue virus or DEN is a small single-stranded RNA virus comprising four distinct serotypes, DEN 1 to 4. These closely related serotypes of the dengue virus belong to the genus Flavivirus and family Flaviviridae. Asian genotypes of DEN2 and DEN3 are frequently associated with severe disease accompanying secondary dengue infections. The vectors. The various serotypes of the dengue virus are transmitted to humans through the bites of infected Aedes mosquitoes, principally Aedes aegypti. This mosquito is a tropical and subtropical species widely distributed around the world, mostly between latitudes of 35 degrees north and 35 degrees south. These geographical limits correspond approximately to a winter isotherm of 10 degrees Celsius. Aedes aegypti has been found as far north as 45 degrees north, but such invasions have occurred during warmer months and the mosquitoes have not survived the winters. Also, because of lower temperatures, Aedes aegypti is relatively uncommon above 1,000 meters. The immature stages are found in water-filled habitats, mostly in artificial containers, closely associated with human dwellings and often indoors. Dengue outbreaks have also been attributed to Aedes albopictus, Aedes polynesensis, and several species of the Aedes scutellaris complex. Each of these species has a particular ecology, behavior, and geographical distribution. In recent decades, Aedes albopictus has spread from Asia to Africa, the Americas, and Europe, notably aided by the international trade in used tires in which eggs are deposited when they contain rainwater. The eggs can remain viable for many months in the absence of water. Humans are the main amplifying host of the virus. In the transmission of the virus, the dengue virus circulating in the blood of viremic humans is ingested by female mosquitoes during feeding. The virus then infects the mosquito mid-gut and subsequently spreads systemically over a period of 8 to 12 days. After this extrinsic incubation period, the virus can be transmitted to other humans during subsequent probing or feeding. The extrinsic incubation period is influenced in part by environmental conditions, especially ambient temperature. Thereafter, the mosquito remains infective for the rest of its life. Aedes aegypti is one of the most efficient vectors for arboviruses because it is highly anthropophilic, frequently bites several times before completing oogenesis, and thrives in close proximity to humans. Several factors can influence the dynamics of virus transmission. These includes environmental and climate factors, host pathogen interactions, and population immunological factors. Climate directly influences the biology of the vectors and thereby their abundance and distribution. It is consequently an important determinant of vector-borne disease epidemic. Clinical manifestations. The infection is usually self-limiting, asymptomatic or subclinical. The incubation period is 4 to 10 days, and primary infection is thought to induce lifelong protective immunity to the infective serotype. Individuals suffering an infection are protected from clinical illness with a different serotype within 2 to 3 months of the primary infection but with no long-term cross-protective immunity. Patients with severe dengue are characterized by plasma leakage with or without hemorrhage, hemoconcentration, and abnormalities in homeostasis. The mechanism leading to severe illness are not well defined, but the immune response, the genetic background of the individual, and the virus characteristics may all contribute to severe dengue. Thrombocytopenia may be associated with alterations in megakaryocytopoiesis by the infection of human hematopoietic cells and impaired progenitor cell growth, resulting in platelet dysfunction and increased destruction or consumption. Hemorrhage may be a consequence of the thrombocytopenia and associated platelet dysfunction or disseminated intravascular coagulation. Symptomatic dengue virus infections were grouped into 3 categories: undifferentiated fever, dengue fever or DF, and dengue hemorrhagic fever or DHF. DHF was further classified into 4 severity grades, including grades 1 to 4, with grades 3 and 4 being defined as dengue shock syndrome or DSS. Grade 1 is fever accompanied by nonspecific constitutional symptoms. The only hemorrhagic manifestation is a positive tourniquet test and or easy bruising. Grade 2, spontaneous bleeding in addition to the manifestations of grade 1 patients, usually in the forms of skin or other hemorrhages. Grade 3, circulatory failure manifested by a rapid weak pulse and narrowing of pulse pressure or hypotension, with the presence of cold, clammy skin and restlessness. Grade 4, profound shock with undetectable blood pressure or pulse. Symptomatic dengue virus infections were grouped into 3 categories: undifferentiated fever, dengue fever or DF, and dengue hemorrhagic fever or DHF. DHF was further classified into 4 severity grades, including grades 1 to 4, with grades 3 and 4 being defined as dengue shock syndrome or DSS. Warning signs include abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement of greater than 2 centimeters, laboratory increase in hematocrit concurrent with rapid decrease in platelet count. Criteria for severe dengue include severe plasma leakage, which leads to shock or DSS, and fluid accumulation with respiratory distress. Second is severe bleeding, and third is severe organ involvement, including liver, which may have AST or ALT greater or equals to 1,000, CNS, impaired consciousness, and includes heart and other organs.
For the differential diagnosis, first is coronavirus disease or COVID-19. So we ruled in coronavirus disease because of the presence of fever, tachypnea, alar flaring, patient was in respiratory distress, decreased breath sounds in both lung fields, decreased O2 saturation, which is at 88%. So we ruled this out because of the absence of dry cough, sore throat, coryza, vomiting, diarrhea, anosmia, and headache. So this can be further ruled out because of the absence of contact with positive COVID-19 individuals within the neighborhood, and RT-PCR swab tests should be taken to confirm this diagnosis. The second differential diagnosis is endotoxin shock from bacterial infection. We ruled this in because of the presence of fever, tachypnea, dyspnea, abdominal distension, and circumoral cyanosis. So this can be ruled out because the patient has marked thrombocytopenia with concurrent hemoconcentration, and to strengthen this diagnosis, blood culture should be taken. Another differential diagnosis is urinary tract infection. So we rule this in because of the presence of fever, bacteriuria, and hematuria. And we rule this out because of the absence of dysuria, flank pain, and pyuria, or the presence of WBCs in the urine sample. We also ruled in pediatric community-acquired pneumonia because of the presence of fever, tachypnea, respiratory distress, alar flaring, crackles, decreased breath sounds in both lung fields, and decreased O2 saturation at 88%, and there's also cyanosis, and we rule this out because of the absence of cough. Lastly, we ruled in chikungunya fever because of the presence of fever, weakness, and lymphopenia at 3 days prior to admission. And we ruled this out because of the absence of joint symptoms on hands, feet, ankles, and wrists, absence of headache, and myalgias.
Patient already manifested severe symptoms of dengue, therefore the treatment should be according to Group C, wherein patients here should require emergency treatment and urgent referral. So the question is, who should be treated under Group C? So any of the following features should be present. First, there should be a severe plasma leakage with shock and or fluid accumulation with respiratory distress. Number 2, severe bleeding. And number 3, there is severe organ impairment. As evidenced in our patient, there is already severe plasma leakage with evidence of hypotensive shock, and also there's already severe bleeding as seen in the gastrointestinal tract. So for Group C, judicious intravenous fluid resuscitation is the essential and usually the sole intervention required. The crystalloid solution should be isotonic and the volume should be just sufficient to maintain an effective circulation during the period of plasma leakage. Plasma losses should be replaced immediately and rapidly with isotonic solution, or if in this case hypotensive shock, we can use colloid solutions that should be given 20 to 48 hours just to maintain or to regain the circulation. So the goals of fluid resuscitation include improving the central and peripheral circulation. This is to improve symptoms by decreasing tachycardia and improve the blood pressure, pulse volume, and the warm and pink extremities, and also the capillary refill time to less than 2 seconds. And improve the end organ perfusion, making the patient stable at a conscious level, and increase the urine output to more than 0.5 ml per kilogram. In managing patients with severe dengue, it is important for us to note the age, the weight, and the height of the patient, since most of the management involves giving IV fluids or bolus. So in the case, it was mentioned that the patient's weight is 58 kilograms and his height is 144 centimeters. So plotting the BMI on the Z-score, it will classify him under obese or overweight. Therefore, we should find for the ideal body weight to be able to calculate or give the correct amount of fluid for the patient, appropriate for the patient. So here we are using the WISHES formula, which is for 7 to 9 years old, and since the patient is 9 years old, we will be using this formula. Expected weight in kilograms equals age in years times 7 minus 5 divided by 2. So the ideal body weight is now 29 kilograms. So we will be using 29 kilograms as our reference in giving computations for the fluids later on. Patient presented with hypotensive shock, it should be managed as follows. First, you should initiate an IV fluid resuscitation with crystalloid or colloid solution at 20 ml per kilogram as a bolus for 15 minutes. As I've mentioned, the ideal body weight is 29 kilograms, so just multiply it by 20, so that will give you 580 ml of crystalloid or colloid solution and given as a bolus. Then, if the patient improves, you should continue to give the crystalloid solution at a rate of 10 ml per kilogram per hour for 1 hour, then reduce it gradually to 5 to 7 ml per kilogram per hour for 1 to 2 hours. Then taper it again for 3 to 5 ml per kilogram per hour for 2 to 4 hours. Then 2 to 3 ml per kilogram per hour for 2 to 4 hours. Then after 4 hours, you observe if the patient is still unstable. Then you should review the hematocrit taken before the first bolus. So if the hematocrit is low, usually in children, if it is less than 40%, this may indicate bleeding. Therefore, you should already prepare for cross-matching and for transfusion. However, if the hematocrit is high compared to the baseline value, then you may change to IV colloids at 10 to 20 ml per kilogram as a second bolus over 30 minutes to 1 hour. Then you can reassess the patient after the second bolus. And then if the patient is improving after the second bolus, then you may reduce the rate from 10 to 20 to 7 to 10 ml per kilogram per hour for the first 2 hours. Then back to IV crystalloids and reduce the rates as mentioned above, the one with 5 to 7 ml per kilogram per hour for 1 to 2 hours, then 3 to 5 ml per kilogram for the next 2 to 4 hours, then until it reaches 2 to 3 ml per kilogram per hour for the next 2 to 4 hours. Then you assess the patient again if it is improving or unstable. If it is again unstable, you may opt to repeat the hematocrit for the second after the second bolus. Then if it remains low, it may indicate underlying mucosal bleeding or gastrointestinal bleeding. For female, maybe you may check the vagina if there is bleeding. And if the hematocrit remains high, you should continue colloid infusion as a third bolus over 1 hour, then reduce again, and then change back to the... So here's an algorithm for fluid management in hypotensive shock. So basically, this just summarizes the things that I've mentioned earlier. And if the picture is not clear, for reference, you may use the World Health Organization manual and just look for figure 2.3, and this will summarize everything that is mentioned for managing patients with hypotensive shock. It is also noted that our patient manifested major bleeding from the gastrointestinal tract, and usually internal bleeding may not become apparent for many hours until the first black stool is passed or if there is presence of hematemesis. So patients at risk for major bleeding are those who have prolonged or refractory shock, and as present in our patient, those who have hypotensive shock and renal or liver failure and or severe persistent metabolic acidosis, those who are given with nonsteroidal anti-inflammatory agents, those who have pre-existing peptic ulcer, those who are on anticoagulant therapy, and those who have any form of trauma including intramuscular injection. Hence, for these patients, blood transfusion is life-saving and should be given as soon as severe bleeding is suspected or recognized. So do not wait for the hematocrit to drop too low before deciding on giving blood transfusion. So you may opt to give 5 to 10 ml per kilogram of fresh packed red blood cells or 10 to 20 ml per kilogram of fresh whole blood. For our patient, I use the average of 5 to 10 for the RBC, which is 7.5. Then that is 217.5 ml of fresh packed RBC. Or you may give a fresh whole blood. So computing this, you will multiply 29 by 15 ml per kilogram. Then that will give you 435 ml of fresh whole blood. Consider repeating the blood transfusion if there is further loss or no appropriate rise in hematocrit after blood transfusion. However, if there is already good clinical response, which may include improvement of hemodynamic status and acid-base balance, then you may stop transfusing blood already. Great care should be taken when inserting a nasogastric tube, which may cause severe hemorrhage and may block the airway. Therefore, it is recommended that a lubricated orogastric tube may minimize the trauma during insertion. Insertion of central venous catheters should come with ultrasound guidance or by a very experienced person.
For the diagnostic tests, viral isolation can be done during the viremic period, usually before day 5. Cell culture is the most widely used method, and virus may be recovered from the serum, plasma, and peripheral blood mononuclear cells. Another test is RT-PCR, which has a better sensitivity compared to virus isolation with a much more rapid results. We also have NS1 tests. NS1 detection is used to make an early diagnosis, but it cannot differentiate between dengue serotypes. Tourniquet test is a test for assessing capillary fragility. The test is said to be positive when you can see 10 or more petechiae per 1 square inch. We also can do CBC. Thrombocytopenia is usually seen in dengue patients. Patient is said to have hemoconcentration if there is an increase of greater than 20% of hematocrit. Neutropenia, decrease in WBC count, prolonged bleeding time, etc. may also be seen in these patients. For the complications, hypovolemia during fluid reabsorption phase can be life-threatening. It is characterized by decreased hematocrit and white pulse pressure. Fluid and electrolyte loss, hyperpyrexia, and febrile convulsions are the most frequent complications. Epistaxis, petechiae, and purpuric lesions are uncommon but can occur at any stage. Dengue hemorrhagic fever is seen in patients from endemic areas presenting with febrile illness with hemoconcentration and thrombocytopenia. Hypovolemic shock is an important complication to look out for in these patients. They will have cold, clammy skin, decreased urine output, tachypnea, tachycardia, etc.
Next, let's discuss prevention according to the WHO guidelines. WHO states that the prevention of and response of dengue and other arboviruses should involve developing and implementing plans. These plans should include early warning systems, epidemiological, entomological, and environmental surveillance, laboratory support, clinical case management, vector and environmental control, and risk communication and social mobilization. The key areas discussed is dengue surveillance, dengue preparedness and response, and program assessment. There are three major components to dengue surveillance. First is disease or epidemiological surveillance. Its purpose is to collect, interpret, and disseminate data which reflects the current health of a community or population. Second is vector surveillance. It is to determine changes in geographical distribution of vectors and provides a relative measurement of the vector population over time. And lastly, the monitoring of environmental and social risks. So its purpose is to identify various factors that influence a community's vulnerability to dengue epidemics. This may include density and distribution of the population, and also environmental conditions that promote the spread of the disease. The second area of discussion is dengue preparedness and response. It is the organization of a multi-sectoral dengue action committee to develop the dengue emergency response plan, review it regularly, and update it as necessary. The two components of the emergency response is first, emergency vector control to curtail the transmission of dengue virus as rapidly as possible, and second is the early diagnosis and appropriate clinical case management of severe dengue to minimize the number of dengue-associated deaths. The final area discussed is program assessment. It aims to identify strengths and weaknesses in programmatic and public health infrastructures that can reduce or increase vulnerability to respond to dengue. It includes the assessment of human resources such as education and training of healthcare workers, the assessment of surveillance systems, to create an efficient plan on data analysis and sharing and response at the lowest operational level possible. The assessment of the diagnostic resources, such as the availability of diagnostic laboratories and staff trained in dengue diagnosis. The assessment of resources of clinical care, such as the anticipation of surge capacity needs and bed occupancy and also staffing needs. Next is the assessment of vector control resources such as the equipments for insecticide application and availability of insecticides. And lastly, the assessment of information products or the promotion of public education on dengue through various means such as posters, media, newspapers, or direct communication. For vaccines, Dengvaxia is a vaccine indicated for the prevention of dengue disease caused by dengue virus. It is a live, attenuated, tetravalent vaccine approved for use in individuals 9 to 16 years of age And take note, with laboratory confirmed previous dengue infection and living in endemic areas. Studies have revealed poor protection of seronegatives and good protection of seropositives with reduction of hospitalization and severe disease. Apparently, seronegative recipients who were incompletely protected were sensitized to experience the enhanced disease of hospitalized dengue. It was then found out that those not previously infected are at increased risk for severe dengue disease when vaccinated and subsequently infected with the dengue virus. Currently, Dengvaxia is licensed for use in 14 countries. Dengvaxia is given in 3 doses, 6 months apart, given subcutaneously. Contraindications of the vaccine is those with history of severe allergic reactions to a previous dose of Dengvaxia or to any component of Dengvaxia. Also, do not administer to individuals with severe immunodeficiency or those who are immunosuppressed. The limitations of use for the vaccines is that it is not approved for those with no previous history of dengue virus infection or those with unknown histories. The effectiveness is yet to be established for those living in non-endemic areas who travel to dengue endemic areas. Other preventive measures is the use of insecticides, repellents, appropriate body covering, and the destruction of breeding sites. Prognosis will depend on the type of disease in which the patient will develop. For patients who develop only dengue fever, prognosis is good. But for those patients who develop dengue hemorrhagic fever, their prognosis is adversely affected by a late diagnosis and delayed or improper treatment. Statistics show that death occurs in 40 to 50% of patients with shock, but with adequate intensive care, death should only occur in less than 1% of cases.